A very good day to Prof. Josh, Dr. Ranjit, and my classmate. Today, me and my group member, Takif, Leong, and Vinisha will be presenting about our seminar topic, Healings of Oral Wounds. This is our learning outcomes. First is to explain the healing process of injuries to oral heart tissues. Second, to describe the factors which promotes or prevent the healing process of heart tissues. Third, to explain the histopathological events of wound healing. And lastly, to describe the factors which promotes or prevent the healing process of soft tissue. Now I will be talking about the type of injuries. First is the physical injuries and second is the chemical injuries. Under physical injuries, they might be due to iatrogenic, self-inflicted, or traumatic cause. Under iatrogenic cause, it might be due to the repair of tooth, restoration of missing tooth, X-ray radiation, or laser radiation. Under self-inflicted causes, it might be due to the overzealous oral hygiene practices, which is caused by psychotic or neurotic conditions, or any habits. Under traumatic causes, it might be due to a fall, fight, road traffic accidents, and sport injuries. Under the chemical type of injuries, it might be due to the drug allergic, which is known as the stomatitis medicamentosa, contact stomatitis, which is known as the stomatitis veninata, and lastly, the non-allergic reaction to the drugs or chemicals. The physical injuries of the heart tissue. The most common physical injury involving the bone is the fracture. So these are the examples of the fracture, which is the fracture of the jaws, maxilla, and mandible. The causes for the fracture may be due to the road traffic, industrial, or sport accident. The fight, blow, or fall might cause the fracture too. As you can see in the diagram on the right side, there are few examples of fracture. So there are 4 types of fracture, which is the simple, green stick, compound, and comminuted fracture. So as you can see in the simple fracture, the bone is broken completely and the overlying structure are intact. For green stick fracture, this is most common in the children and there will be a break of bone in one side and bend on the other side. So for compound fracture, the external wound is associated with the break and is common in a road traffic accident. In comminuted fracture, the bone is crushed and it may or may not be exposed to the exterior. So, other than the fracture, the physical injury to the heart tissue can be the traumatic bone cyst, which is known as the Shildorf cyst or solitary bone, or the focal osteoporotic bone marrow defect of the jaw, or the surgical ciliated cyst of maxilla, which is also known as the sinus mucosal. For traumatic bone cyst, this is most commonly happen in the posterior region of the mandible. So they might be swelling but seldom with pain. So in the radiographic features, it appears radiolucent with the sclerotic border, and it is usually 1 cm in the diameter. And the radiolucency appears to involve the roots of the teeth. So you can see the features in the diagram below. The focal osteoporotic bone marrow defect of the jaw. So this is an uncommon lesion producing a focal radiolucency away from the normal hematopoietic marrow. So this is usually asymptomatic and can only be discovered during the radiographic examination. So as you can see in the radiograph, there is obvious osteoporosis and thinning of the cortex, and it shows the radiolucency of variable size from few mm to few cm. So it has the poorly defined peripheral indicative of the lack of reactivity of the adjacent bone. Surgical ciliated cyst of maxilla. So this is the cyst that develop either after surgical entry into the maxillary sinus, usually a Cordell Look surgery operation, or due to the obstruction of ostrum. So this is the implantation type of cyst in which the epithelium of the maxillary sinus become entrapped along the line of the surgical entry into the sinus, and it subsequently proliferates to form a true cystic cavity anatomically separated from the sinus. As you can see in the diagram on the right side, there is a cyst-like lesion that occur near to the maxillary sinus. Coming to the physical injuries of the soft tissue, so these are the examples. So first, the linea alba. Linea alba is actually a white line seen on the buccal mucosa, extending from the commissure to the posterior at the level of the occlusal plane. So it can be caused by the physical irritation or pressure exerted by the posterior teeth. And this is usually seen bilaterally as seen in the left diagram. So for toothbrush trauma, this is the injury that occurred to the gingiva and is caused by toothbrush. And it appears white, red, or ulcerative, usually accompanied by pain and burning sensation. Next is the traumatic ulcer. This is caused by several forms of trauma, for example, by biting the mucosa, the denture irritation, toothbrush injury, and the exposure of mucous membrane to the carious region or the sharp teeth. So in the diagram on the right side, this is known as the cotton roll injury. And this is a common reaction when the dry cotton roll placed by the dentist is roughly or harshly removed, and so the mucosa adhering to it is torn. So the other example of the physical injuries of soft tissue are the generalized inflammation, which is known as the denture sore mouth, also known as the denture stomatitis, the inflammatory hyperplasia, which is known as the denture injury tumor, the denture-based intolerance or allergy, cervical facial emphysema, and the anesthetic necrosis. So this injury will be explained in the following slides. So generalized inflammation. So this is an uncommon condition occurring in a patient who may or may not have a new set of denture. This usually occurs due to the fungal infection by the Candida albicans, or the continual denture wearing, or the poor oral hygiene habits. So the clinical feature would be the mucosa beneath the denture become extremely red and swollen, and it appears smooth or granular. So the patient usually have the complaint of painful and severe burning sensation. So the redness of the mucosa is sharply outlined and restricted to the tissue in contact with the denture. Next, the inflammatory hyperplasia. So this is one of the most common reactions to the chronically ill-fitting dentures. So there will be occurrence of hyperplasia tissue along the denture borders, which is the development of elongated row of tissue in the mucolabial or mucobuccal fold area. So the proliferation of tissue is slow. There might be the resorption in the alveolar ridge due to the trauma or loose denture, and the lesion is firm to the palpations. As you can see in the picture above, there is development of the hyperplasia tissue, and on the diagram on the right bottom side, this shows the elongated row of the tissue. Coming to the cervical facial emphysema, so this is a swelling due to the presence of gas or air in the interstitial spaces of the connective tissue. This might happen after a variety of oral and denture procedures, such as tooth extraction or blowing of the air into the root canal during the endodontic treatment. This is an unilateral swelling which occurs very rapidly, and this is very painful. So when you palpate the tissue, you'll feel a bubbling sensation on the swelling. Lastly, the anesthetic necrosis. So this is due to the administration of local anesthetic, which can cause the ulceration and necrosis at the site of injection. It usually appears few days after the procedure. As you can see on the diagram, this is a well-circumscribed area of ulceration and is most commonly happen on the hard palate. So the possible causes of the anesthetic necrosis is the epinephrine content in the local anesthetic solution, the administration of excess solution in the tissue which is firmly bound to the bone, or the subperiosteal injection. Now I'll be talking about the radiation injuries. So the radiation effects on the mucosa is actually depend on the source of radiation, the total amount of radiation administered, the period of time over which the radiation administered, which is known as the fractionation, the type of filtration used, and the total area of the tissue irradiated. So these are the effects of radiation on the oral and paraoral tissues. So first is the bilateral parotitis, partial xerostomia, oral mucositis, which can be seen on the diagram above, which shows the whitish, soreness, and the swelling of the mucosa. So the erythema, which means the reddish of the mucosa, hyperemic, which means the increased blood flow to the area, edematous, and slowly it will become a denuded, ulcerated mucosa covered with a fibrinous exudate, and this will lead to the great discomfort and pain. And lastly, if there is a heavy radiation to the bone, osteoradionecrosis will occur. Osteoradionecrosis. So this is a chronic painful infection and necrosis accompanied by the late cicatrization and sometimes permanent deformities, as you can see in the diagram on the right side. So these are the factors that might cause the osteoradionecrosis. First is the irradiation of an area of previous surgery before an adequate healing had taken place, irradiation of lesion in close proximity to the bone. A high dose of irradiation is used with or without the proper fractionation, use of a combination of external radiation and intraoral implants, patient with poor oral hygiene and continued use of irritants, poor patient cooperation in managing irradiated tissue or fulfilling the home care programs, indiscriminate use of prosthetic appliance following irradiation therapy, failure to prevent trauma to irradiated bony areas, and the presence of numerous physical and nutritional problems prior to the therapy. Coming to the non-allergic reaction to drugs and chemical locally, so the first example is aspirin. So aspirin is a local obtundant, especially for relief of toothache. So how do you use it is by putting the aspirin tablet on against the tooth and with the help of the cheek and lip to hold it in the position. And after a few minutes, you will feel a burning sensation, and this might cause the separation of the epithelium and frequent bleeding of the area. So next is the endodontic bacteria such as paraformaldehyde, which is used for the revitalization of the pulp, and sodium hypochlorite, which is used as a root canal irrigant. So these two materials may leak from the pulp chamber into the surrounding tissue and may cause the necrosis of the gingiva and the bone. So next, the catapulta. Catapulta is used to fill the empty spaces inside the tooth roof with the help of zinc oxide eugenol to attend the apical seal. So in this case, it may cause the transport of bacteria into the apex, and incomplete cleansing may cause the bacterial infection. So for sodium perborate, this is used widely as a mouthwash, bleaching agents, and in dentifrices due to its therapeutic effect on the gingiva disease. So this material may cause the erythema of the oral mucosa, which progress and form sloughing of the tissue. If it aggravated, edema and ulceration of mucosa will happen. So for phenol and nitrate, these are the cavity sterilizing agent, topically as a caries preventive agent and chemical cautery. So overzealous use may produce a painful burn of the oral mucosa and the skin. Coming to the last part, which is the occupational injuries. So these are the examples, which is the chemical workers, insecticide makers, battery and paint makers. So these are the person who has a high chance of exposing themselves to the harmful chemicals. So these harmful chemicals are the bismuth, lead, mercury, and arsenic. So on the right side, it is the bismuth line and lead line. So it appeared as a blue-black line on the gingiva margin, and this is caused by the pigmentation of the sulfide on the gingiva. So other than that, you will normally experience the burning sensation on the mucosa, the excessive salivation, and sometimes with the gingivitis, and also you will have the metallic taste in your mouth.
Hi everyone, my name is Takif and I'm going to talk about healing process of injured tissues. So what is healing? Healing is replacement of damaged tissue by living tissue to restore function. They are one of the most important mechanisms for a human body. Damaged tissue can be repaired by itself through different processes. Now let's talk about the process of healing. It consists of wound contraction by myofibroblasts with characteristics of small muscle cells. This contraction will cause reduction in size of the wound in the first few weeks, and lost tissue will be replaced, along with division and migration of neighboring cells. If the lost tissue is replaced by granulation tissue, it is known as repair, which also results in scarring. However, if the lost tissue is replaced by similar type of tissue, it is known as regeneration. This allows damaged tissues to regain their integrity and functionality after an injury. If the edges of the wound is proximated, the healing process will be faster and is also known as primary healing by first intention, or can also be called as primary healing. But if the tissue loss in wound edges cannot be approximated, it will reduce in size by contracting. Granulation tissue will fill the wound, and there will be epithelialization occurring throughout the wound surface. Epithelialization is the process by which the skin and mucous membrane replaces the superficial epithelial cells. Granulation tissue. Characteristically, it is bright pink in appearance, composed chiefly of proliferating capillaries and fibroblasts. There will be various growth factors and cytokines that play a significant role in healing. These examples of growth factors would be epidermal growth factor. It produces by the epithelium around the damaged area to help in regeneration of the epithelial tissue. Endothelial growth factor. It triggers the formation of new blood vessels. Macrophages. It stops fibroblast activity along with transforming growth factor A. In histopathological events, healing of tissue wounds can be divided into two. Healing of soft tissue wounds, that includes primary healing and secondary healing. Healing of hard tissue wounds will include healing of extraction wound, healing of fracture, and healing of gingivectomy wound. Now moving on to healing process of injuries to oral soft tissues. So primary healing. Primary healing is a healing that occurs after the excision of a piece of tissue with the close apposition of the edges of the wound by sutures. When the edges of the wound are brought into contact and are held in place by sutures, the blood clots, and in a matter of hours, numerous leukocytes are mobilized into the area. Then the connective tissue cells in the area undergoes transformation into fibroblasts, which in turn undergo mitotic division, and the new fibroblast begins to migrate to the line of incision. In time, these cells will form thin, delicate collagen fibrils, which intertwine and coalesce in a general direction parallel to the surface of the wound. Then, endothelial cells of the capillaries begin to proliferate. Small capillary buds grow out and across the wound. New capillaries are formed, filled with blood, and a rich network of young capillaries and capillary loops are formed. In this picture, this thin linear incision shows regeneration of the damaged tissue, which occurs quite rapidly. Moving on to secondary healing. Secondary healing, or healing by secondary intention, is healed by granulation tissue or healing of an open wound that occurs when there is loss of tissue and the edges of the wound cannot be approximated. This type of wound is usually filled with granulation tissue and is usually a result of a biopsy of a lesion in an area of an oral cavity in which tissues are not pliable and not approximated. Example of a secondary healing would be removal of a lesion of the palate or large lesion of the alveolar ridge. The fibroblasts and capillaries have a greater distance to migrate, and the healing is usually slower, and cellular proliferation begins around the periphery, and fibroblasts and endothelial cells grow into the clot along fibrin strands. Then polymorphonuclear leukocytes, lymphocytes, and mononuclear phagocytes migrate into the granulation tissue from the adjacent vessels and tissues. Large numbers of leukocytes accumulate on the surface of the wound. When granulation tissue matures, it becomes more fibrous through condensation of collagen bundles. Surface of the granulation tissue is epithelialized. As in primary healing, the collagen fibers coalesce and the lesion becomes somewhat less vascular. So here is a picture of the differences between primary healing and secondary healing.
Thank you, Takif. Now next would be the healing process of injuries to oral hard tissues. So firstly, there will be the healing of extraction wound. Now the immediate reaction following extraction would be blood which fills the socket will coagulate. The RBC, red blood cells, will be entrapped in the fibrin meshwork, ends on the torn blood vessels in the periodontal ligament becomes sealed off. Now, the hours after tooth extraction are critical, for if the blood clot is dislodged, healing may be greatly delayed and may be extremely painful. Within the first 24 to 48 hours after extraction, there will be alterations in the vascular bed. Vasodilation and engorgement of the blood vessels in the remnants of the periodontal ligament, and there will be mobilization of leukocytes to the immediate area around the clot. The surface of the blood clot is covered by a thick layer of fibrin. The clot itself shows areas of contraction. The collapse of the unsupported gingival tissue into the opening of a fresh extraction wound is of great aid in maintaining the clot in the position. So now for the first week of the extraction of wound histologically, as seen in the diagram beside, there will be first proliferation of fibroblasts from connective tissue cells in the remnants of the PDL. These fibroblasts will then begin to grow into the clot around the entire periphery. This clot forms an actual scaffold where the cells associated with the healing process may migrate. However, this is only a temporary structure and it is gradually replaced by granulation tissue. The epithelium at the periphery of the wound exhibits evidence of proliferation in the form of mild mitotic activity. The crest of the alveolar bone will then exhibit the beginning of osteoclastic activity. The endothelial cell proliferation will be at the beginning of the capillary ingrowth, which may be seen in the PDL area. Now, the blood clot will undergo organization around the periphery of the fibroblast and occasional small capillaries from the residual PDL. The remnants of this PDL are still visible. Extremely thick layer of leukocyte forms around the surface of the clot. The edge of the wound would continue to exhibit epithelial proliferation. In the second week of the wound extraction, the blood clot will become organized by fibroblasts growing into the clot on the fibrinous meshwork. New delicate capillaries will then penetrate to the center of the clot. The remnants of the PDL gradually will undergo degeneration and will be no longer recognizable. Instead, the wall of the bony socket now will appear lightly frayed. In some instances, trabecula of ostoid can be seen extending forward from the wall of the alveolus. Epithelial proliferation over the surface of the wound is extensive in the case of large posterior teeth. The wound is not usually covered. In smaller sockets, epithelialization may be complete. The margin of the alveolar socket exhibits prominent osteoclastic resorption. Fragments of necrotic bone, which may have been fractured from the rim of the socket during the extraction, are seen in the process of resorption or sequestration. In the third week of extraction of the wound, the original clot appears almost completely organized by maturing granulation tissue. Very young trabecula of ostoid or uncalcified bone form around the entire periphery of the wound from the socket wall. This early bone is formed by osteoblasts derived from pluripotential cells of the original PDL, which assumes as an osteogenic function. The original cortical bone of the alveolar socket undergoes remodeling so that it no longer consists of such dense layer. The crest of the alveolar bone is rounded off by osteoclastic resorption. The surface of the wound may have become completely epithelialized. Finally would be the fourth week of the extraction wound, where there will be continued deposition and remodeling resorption of the bone filling the alveolar socket. Remodeling will continue up to several weeks. However, radiographically, there is evidence from its radiolucency where early bone is poorly calcified. The radiographic evidence of bone formation does not become prominent until the 6th or 8th week after tooth extraction. Radiographic evidence will show differences in the new bone of the alveolar socket and the adjacent bone in some cases. The diagram at the side shows the tooth before extraction and the socket after 2 weeks of extraction. These diagrams show after 1 month of extraction, 2 months of extraction, 8 months and also 14 months of extraction of how the socket would appear. Since the crest of alveolar bone undergoes a considerable amount of osteoclastic resorption during the healing process and the bone filling the socket does not extend above the alveolar crest, the crest of the sealed socket is below that of the adjacent teeth. Next would be the healing of fracture. So the immediate effects of a fracture would be the Havasian vessels of the bone, vessels of the periosteum, and the marrow cavity that happen to cross the fracture line will be torn as seen as the diagram above. This will result in acute inflammation in the soft tissue adjacent. This will cause the circulation to stop as proximal to the fracture site as there is an anastomosis of undamaged vessels. When the blood flow in the vessel is interrupted, the bone cells or also the osteocytes of the Havasian system supplied by this vessel will die. The dead bone extends away from the fracture area to the site of the anastomosing circulation. Now would be callus formation. Callus is basically uniting the fractured ends of the bone and it is composed of varying amounts of fibrous tissue, cartilage and also bone. The external callus consists of the new tissue which forms around the outside of the two fragments of the bone. The internal callus is the new tissue arising from the marrow cavity. Cells of the periosteum immediately adjacent to the periosteum torn at the fracture line will usually die. Formation of a small amount of new bone begins at some distance from the fracture. The diagram above shows the callus formation. The continued proliferation of these osteogenic cells forms a collar of callus around or over the surface of the fracture. The new bone which begins to form in the external callus usually will consist of irregular trabecula, often laid down at right angles to the surface. This differentiation of cells into osteoblasts and subsequent formation of bone away from the fracture line, there will be a number of cells of the osteogenic layer differentiating into chondroblasts to form cartilage. This cartilage will then fuse with the bone, although there is no sharp line of demarcation. The internal callus will then form from the endosteum of the Havasian canals and undifferentiated cells of the bone marrow. The new bone formed at the end of each fragment gradually unite and establishes the continuity of the bone. Remodeling of callus is basically when the external and internal calluses must be remodeled because there is always an abundance of new bone produced to strengthen the healing site. The new bone is frequently joined with fragments of the original dead bone. These fragments are slowly resorbed and replaced by a mature type of bone, which follows normal stress patterns. The external callus should be remodeled so that the excess bone can be removed. The last part would be the healing of gingivectomy wound, where they are divided into early healing phase and late healing phase. For the early healing phase, after 2 days, delicate connective tissue proliferation would occur. Epithelial cells bordering the wound would undergo actual epithelialization. After 4 days, superficial portion will exhibit dense number of polymorphonucleoleucocytes entrapped in the fibrinous meshwork. Proliferation of young capillaries and fibroblasts into the base of clot would also occur. The epithelium extends over a portion of the wound below the necrotic surface layer of the clot, but it will be above the proliferating and organizing connective tissue. Finally, for the late healing phase, epithelialization will complete within 10 to 14 days. The thin epithelium will begin to mature and form rete packs only after 2 weeks of interval. The inflammatory cells would have largely disappeared except for those in the subepithelial zone. The surface epithelium will grow downwards along the surface of the cementum within a month. The diagram below will show day 3, day 7 and also day 14 of the healing of gingivectomy wound in the late healing phase.
So thank you, Manisha. I'm Leong. I'll be talking on factors affecting healing of hard and soft tissue. So hard tissue mainly is the tissue which are mineralized and consists of intercellular matrix, whereas soft tissue is the opposite. and it mainly includes those injuries or wounds on the gingival, gum, gingival is the gum, buccal mucosa, and also the lips. So for the hard tissue, is also include those fracture of the jaw and fracture of the bone. This is the open fracture, closed fracture, and complicated fracture. So as you can see for the picture on the left side here, this is a picture of toothbrush trauma, mainly due to improper brushing technique using a stiff texture toothbrush. And the picture of the top here, the right, top right here, is the picture of linea alba on the buccal mucosa, and the picture of right bottom here is the picture of traumatic ulcer on the lower lid. So these three pictures are actually the example of injury or wound on the soft tissue. Whereas for this, in this slide, you can see that this is the common example of healing on hard tissue, which include the fracture of the jaw, the maxillary and mandibular arch, and also the fracture of the bone. So the picture on the left side, you can see that this is the picture showing the maxillary and palatal fracture. Whereas at the right bottom, the right top, sorry, at the right top, you can see that there's the picture of mandibular fracture, and at the right bottom, this is the picture of open fracture, mainly due to car or motor accident. Okay, moving on. So here's a chart showing the factors promoting wound healing and the factors delaying wound healing. So the factors which promote wound healing is mainly just the opposite of those that delaying it. Example, young age is going to promote wound healing, whereas increasing age is going to delay the wound healing. And good nutrition status and good blood supply are going to promote it, whereas poor nutrition status and poor blood supply are going to delay it. Same goes to clean environment without any necrotic or tissue debris is going to promote it, whereas necrotic environment is going to delay it. And immobilization with restricted movement is going to promote the wound healing, whereas exaggerated movement is going to delay the healing. And good health is going to promote, whereas disease like diabetes, infection, trauma, and pressure may delay wound healing. And next is hyperthermia, increase in body temperature will promote wound healing, whereas hypothermia, decrease in body temperature, will delay it. And then next is hormone, absence of ACTH, also known as adrenocorticotropic hormone, is going to promote wound healing, whereas the use of corticosteroid will delay it. And the last one is low dose of X-ray can promote wound healing, whereas radiation therapy or chemotherapy will delay the wound healing. Okay, next will be local factors. So local factors means the factors that is local to the wound itself. That means the problem is within the wound itself. So the first one is location. So the wounds in an area with good vascularity will heal more rapidly than wounds in an area which is relatively avascular. Meaning that in an area with good blood supply, the wound is going to heal more faster than the one in poor blood supply. Next will be immobilization. Immobilization means restricted movement. If the wound is suggested to constant movement, it's going to result in delay because the formation of new connective tissue is disrupted. That's why it's better to immobilize the leg of a patient after a motor accident. Next will be desiccation. Desiccation means extreme dryness of the wound, or we say removal of moisture from the environment. It's ideal to say that a wound is going to heal more rapidly or better if the wound is moist and warm, because if a dry wound happens, it's going to be more painful and heal more poorer than those with moist and warm one. Because in dry condition, there will be formation of scab and excess crust over the wound. And also, the epithelial cell migration is going to delay, also known as the process of epithelialization, is going to delay. That's why in desiccation, the wound finds itself hard to heal. Okay, next, number 4 will be the pressure over the wound site. So the pressure over the wound site, if it is excessive or sustained, is going to result in delayed wound healing too, because the formation of new connective tissue is disrupted, and the blood flow to the surrounding area over the wound is also disrupted. That's why if the pressure is excessive over the wound site, the healing of the wound is going to be delayed. Okay, now I'll be talking on physical factors. So the first one will be trauma. So severe trauma to tissue is an obvious deterrent to rapid wound healing. Deterrent means disturbance or discourage. So we mean that in trauma, there will be delayed wound healing. So the picture on the right shows that oral mucosa trauma and injuries in the maxillary arch in the oral cavity. However, study has shown that in mild traumatic injury, there may be favor healing process. And it also well recognized that a second wound inflicted by the healing site of an initial wound is going to heal more rapidly than the initial wound. Okay, next will be age of the patient. Wound in younger person heal considerably more rapidly than in elderly person. Meaning that, in other words, we can say that the age of the patient is inversely proportional to the rate of healing process. So it means that when the patient age getting older, the rate of wound healing is going to decrease. This is because study has shown that the patient over the age of 60 is going to have less formation of collagen, which is important in the formation of skull, and also there will be decreased angiogenesis and epithelialization process, which is seen more faster in younger patients. That's why in patients with older age, they find it hard for the wound to heal. Okay, next will be local temperature. So hypothermia may promote wound healing, while in hypothermia it is delayed. Hypothermia means increase in body temperature, whereas hypothermia means decrease in body temperature. This is due to the action on cell multiplication and local circulation. Like I said earlier in the previous slide, it is ideal for a wound to heal under moist and warm condition. That's why in desiccation, the healing is delayed. Same goes to here. The cool tissue is going to undergo vasoconstriction, and there will be increased hemoglobin needs for oxygen. As a result of this, there will be less adequate amount of oxygen for the type of fibrous cell known as neutrophil to fight off infection. That's why in hypothermia, the wound healing is delayed. Okay, let's move on to X-ray radiation. So low dose of radiation tend to stimulate healing, while larger dose tend to suppress healing. This is because larger dose of X-ray radiation is going to cause active cell apoptosis, inactive cell proliferation, and cell cycle is arrested. So this factor is going to delay wound healing because of the inactive cell formation and active cell being destroyed. Okay, next is the fifth one, that is circulatory factors. In anemia and dehydration, the wound healing is suppressed. This is because in anemia, there's lack of red blood cell, so the blood supply is restricted. So that's why there will be poor circulation of blood flow, and the healing is delayed. Whereas for dehydration, like I mentioned earlier, a wound is going to heal more rapidly if it's under moisture and warm condition. So in dehydration, there is dryness of the wound, so the healing is also delayed. Next will be nutritional factors, which include protein and vitamins. So these two proteins and vitamins is going to play an important role in the healing process, because in nutritional deficiency, the body is going to lack of resources to make a repair or regeneration of new cell over the wound site. That's why these resources is going to make a difference in wound healing. So I will start with protein first. So they influence the speed of wound healing, and when there is deficiency of protein, they are going to cause a delay in the formation of new fibroblasts as well as decrease in the fibroblast multiplication over the wound site. And study has shown that the incorporation of methionine, which is an essential amino acid in human body, into the hypoproteinemic animal, which means the animal with protein deficiency, is going to restore the rate of healing process back to normal, which means that the incorporation of protein is going to make a difference in the process of healing of the wound. Okay, next will be vitamins. So the most important vitamin is vitamin C or ascorbic acid. So on the left, you can see the picture of vitamin C or ascorbic acid. So this vitamin is going to add through regulation of collagen formation and formation of normal intercellular ground substance of the connective tissue. And it said that the inhibitory effect on wound healing is specifically related to interference with the production of mucopolysaccharide. And there were studies shown that in the wound of a scorbutic animal, so scorbutic animal refers to animal that is associated with vitamin C deficiency. In this animal, the proliferation of fibroblasts is going to continue much longer than those in control animal, and there will be decreased tensile strength of the healing wound in this animal. This is because in animal with vitamin C deficiency, scorbutic animal, the healing is much more slower. So they require more or longer proliferation of fibroblasts in order to attain a desired wound healing compared to animal with normal vitamin C production. That's why in scorbutic animal, the healing is delayed. Also, there were studies show that the vitamin A and vitamin D present in the cod liver oil helps in repair of wound healing. And also, there are some vitamin B which are important also in the healing process, which are the vitamin B2 known as riboflavin and vitamin B6 known as pyridoxine. Next, moving on to infection. So wounds which are completely protected from bacterial infection actually is going to heal considerably more slowly than those are exposed to bacteria or other mild physical irritation. Or we say that in other words, we can say that in germ-free state without any bacterial infection, the healing is going to be much slower than those are exposed to slight bacterial infection, because in those which are not exposed to any bacterial infection in the germ-free state, the healing of the oral wound is delayed because the tensile strength of the wound is decreased. And there were studies shows that the bacterial infection of wound is going to suppress the cortisone inhibitory effect on fibroblastia in the experimental animal. So when there is no bacterial infection at all, there won't be any formation of fibroblasts, which is important in the process of healing. That's why in germ-free state, there will be delayed wound healing. However, in severe bacterial infection of wound, of course there will be decreased wound healing or slow healing process. This is because severe bacterial infection is going to trigger the body immune response and also cause inflammation and damage to the tissue. That's why this is going to delay wound healing. So here's the picture of wound healing problems due to infection on the oral cavity. Okay, next moving on to hormonal factors. So the first one is adrenocorticotropic hormone, ACTH, also known as corticotropin. They will delay wound healing in patients with this intake of hormone due to inhibition of growth of veneration tissue. Veneration tissue is normally bright pink in color and it consists of proliferating capillaries and fibroblasts. There will also inhibition of proliferation of new fibroblasts and new endothelial sprout. And there will also depression of the inflammatory reaction. So these few reasons contribute to delay wound healing in patients with this intake of hormone. That's why in the industry, it's better to take proper case history before assessing a patient with Cushing syndrome due to excessive cortisol hormone. So the next one is diabetes mellitus due to deficiency of insulin. In diabetes mellitus, there will be significant retardation in repair of wound after surgical procedure. The wound in diabetes patients are notoriously slow to heal, and frequently they show complication in the repair process. Normally, the diabetes mellitus, the patient is going to suffer the ulcer or wound on the leg, but there can be also complication on the oral cavity. So on the picture on the right, you can see that there is minor mucosal ulceration on the lower leg. So this is the example of oral complication of diabetes. The reason why diabetes is delayed wound healing is mainly due to probably due to disturbance in the carbohydrate metabolism at the cellular level in the local area of the wound. That's why in diabetes there is a significant delay in the healing of the wound, or we say slow healing process compared to normal person. So that was my last slide, and that's all from us. So this is our reference. And thank you for listening, and have a nice day.